Thank you. Thanks to all of our witnesses. I appreciate the work very much. Mr. Topchick, I want to be able to drill down with you a little bit. You've been at this for 2 decades and getting a chance to be able to research rural hospitals. We were not dealing with the number of rural hospital closures 3 decades ago that we are now. So what has shifted in those 3 decades? That 3 decades ago, we're opening rural hospitals and now we're closing rural hospitals. What has shifted?
Rural hospitals predominantly rely upon Medicare and Medicaid reimbursements. And as rural hospitals' expenses have continued to climb, especially recently with the inflationary pressures, staffing challenges have continued to grow. New technologies are required to do business today that didn't exist 3 decades ago. All of this is very expensive, and the reimbursements have not kept up. I think that's the simple answer. We see declining reimbursements relative to the fixed costs of operations.
What do those reimbursements need to be for a rural hospital as far as percentage increase to be able to make the math work for them? And I know it's going to be different for different hospitals. I understand the administrative structure, so there's not one size fits all, but what are we talking about?
Right. I think it was this committee under Senator Baucus's leadership that recognized this low volume problem, and we created a cost-based reimbursement system, cost-based plus, and over time, if my consulting peers would suggest that even at the beginning of that program, it was probably in the high 90th percentile of the actual costs of running a hospital. And today what we hear is it's probably more like 90%. So what that difference is and how to make up for that, I think, is something that we would need to look at more carefully. But your question is spot on. There's a lack of reimbursement, and what that gap is, it continues to widen as we've seen. 10 years ago, Senator, when I was looking at this data, a third of rural hospitals were in the red, and today it's 50%.
Right. The other challenge has been staffing for rural hospitals. That's been significant. There is a new CMS rule that is out right now dealing with staffing for nursing homes, which I think disproportionately will hit rural nursing homes as well in staffing. Their solution is to increase the quality in nursing homes, just increase the staffing, just hire more people and to be able to add into it. The challenge that I have is, obviously, if they're going to hire more nurses there at rural nursing homes, they're going to come take them from rural hospitals to be able to get there, to be able to maintain this. There's a limited number of people that are already there to be able to do it. How do we deal with the staffing issues in rural America, knowing that the DC solution is just, if there's not enough staff, just hire more people? How do we deal with that?
Senator, I appreciate the question. The entire panel was having a discussion in the antechamber just before this about threading that needle and how challenging it is. I think all of us can get behind additional staffing and higher quality of care for our seniors in long-term care. I'm comforted when I looked at the final rule that there were recognitions of rural challenges around being in a high healthcare professional shortage area to begin with. How can we, if we're in a shortage area, meet these challenges? But I saw then provisions to give a timeline that was extended, as well as waivers in those cases where it's not possible. So on the one hand, threading the needle, Senator, I like the idea of increased quality of care for my dad, for example.
Sure.
But I totally understand that the hospitals whom I serve, they are now facing an additional burden, and that's the challenge.
Yeah, it is a challenge. When I went through the rule as well, you've got 3 years to get there for an urban and 5 years to be able to get there for a rural. I think the challenge is going to be is that the urban are going to basically hire as many people as they possibly can, and it puts the rural behind then, even farther behind, because the urban have a faster deadline to be able to get there. The other challenge is going to be the waivers, as you mentioned before. If you request a waiver and get it, you've got to publicly display that you've got a waiver, that you're operating under a waiver. You've got to tell every future family that's considering it you're operating under a waiver. So while you could request a waiver, it seems like the first step towards closure to announce that you have a waiver, because now you're not going to have families take you up on it, because they're going to go, okay, you're a problem facility, you're operating under a waiver. So it puts you as a stigma right at the beginning, which I think would decline even faster there. So there are some real challenges on the waiver process that I think actually will lead to more rural closures than actually more opportunities there. And time will tell on that, but that's one I'm hopeful that CMS will actually take up, and to be able to take a harder look at that same issue on this. For all of you, I'd love to be able to sit and visit with you for hours, because we've got lots of questions on it, but obviously there's a lot of us that want to be able to drill down these issues. Thanks for your testimony and for the time to be able to put into this.
Thank you, Senator.
Important